Okay, guys, this is the Module 27 Intracranial Regulation focused on seizures PowerPoint with narration that I promised you. If you'll look at your book, we do this out of Chapter 11. You will notice there are a couple exemplars in that chapter, but we're going to focus on 11.2. Now, if you go to the front of that chapter, you're going to find some good information on neuro assessment, and also the cranial nerve function and things like Glasgow Coma Scale. All of those assessment type things are fair game when we're dealing with looking at disorders of the brain. So if you need to review Glasgow Coma Scale, if you need to review cranial nerves, the front part of that chapter is really good and it breaks down the neuro assessment. So go back to that if you need to. But going forward to the content, this slide gives you your objectives, and these are straight from your syllabus. And then we go into the content here with seizures. So if we could define seizures, seizures would be a period of abnormal electrical discharge in the brain. We know that our brain depends on electrical discharges. That's a normal way it messages from one nerve cell to another to get one message from point A to point B. And all that's a very normal occurrence that happens. But when something comes along that triggers an extreme response in the brain of that electrical discharge system, we start to have problems, and seizures is a manifestation of that. So with increased electrical discharges, we have increased excitability of the cells, and this abnormal excitability over what is considered a normal threshold of activity would start to show us some symptoms in the patient. So we might see alterations in their movement, in their behavior, in their level of consciousness, and even in their sensory perception of their environment. So all this stuff, direct result of what's going on in the brain. Now, to say that someone has epilepsy is a diagnosis, but it's not one isolated seizure. It is characterized by recurrent, a trend of or a pattern of unprovoked seizures. For instance, if a child has a febrile seizure, we know that comes from a fever. We know there's an underlying cause, so that child would not be diagnosed as epileptic. But if we've got some other unprovoked seizure activity going on and there's a pattern of it, and usually it's secondary to some sort of CNS disorder, then we would diagnose this person with epilepsy. So important to understand there that one seizure does not make someone epileptic. It is a pattern over time. So with the patho here, we're thinking about what's going on in the brain. Usually you have some sort of trigger that comes along and causes this excitability, causes this abnormal discharge in the brain. So our normal acute insults that we think about, infection, hypoxia, fever, bright lights even, if you think about the warnings that are on video games about may induce seizure activity, bright lights kind of going off and on can be an insult to the brain to cause a hyperactive electrical discharge. Patients going into DTs, there's a chemical imbalance in the brain that's associated with that process that causes or puts someone at risk for seizures. So when we look at seizures overall, we'll say that they can be focal or generalized. So that's two classifications of the seizure. And it has to do with the area of the brain that's affected. So a focal seizure would typically affect one hemisphere, one area of the brain. So then what you would see in the patient is usually one-sided, one extremity, maybe one area of the face, very localized manifestations. The flip side of that is a generalized seizure that can affect both hemispheres of the brain. So then you would expect to see symptoms in the patient that would be maybe bilateral as far as all over their body, or maybe both their arms or their whole face. So you would get a manifestation of something that was more encompassing. when it's a generalized seizure. We do recognize that whether it is a focal or generalized seizure, that there's going to be these involuntary movements, behaviors, or sensory alterations. And we do understand that epilepsy is a chronic seizure disorder. Once someone is diagnosed, they're probably looking at lifelong management of seizure disorder, unless the underlying treatment or the underlying problem can be treated. So what causes them? Some seizures are what we call idiopathic, meaning that the cause is unknown. We're not really sure why it happens. Others are caused by some underlying pathology. Maybe they had a head injury that altered their brain chemistry, altered their brain structure or function. Maybe there was a tumor pressing on a part of the brain that causes disruption in the nerve conduction. Maybe a stroke. Metabolic disorders where hormones are abnormal and we get that excitability from neurotransmitter problems in the brain. So some we kind of know what's going on, some not. A very special case of seizures is called febrile seizures, and we generally see this in children. A result of a temperature rise, usually above 102 degrees Fahrenheit. In practice, what you'll usually see is a child that has at least 103, more commonly 104. These tend to be high readings in children. And what would be the reason? Why is it that we see febrile seizures in children and not adults commonly? And the reason would be because children have a lower convulsive threshold than adults do. And that's because they have an underdeveloped CNS. So as they get older, their risk goes down, and so that's usually kind of takes care of itself if it's just a childhood history of a febrile seizure. So it doesn't necessarily mean they're going to develop epilepsy. But we do know that once a child has one febrile seizure, they are prone to have others. The peak age of this for children is 17 to 24 months. And then, like we said, as the child gets older, the risk goes down. Other risk factors here: infants that are small for their age. Thinking about maybe a preemie or a baby that was having trouble gaining weight. There might be a risk factor there based on their underdeveloped CNS. We've talked about brain tumors and stroke, neurological conditions, autistic disorders, anything really here on this list you can think of that alters brain function, brain chemistry, or brain structure. You could about attribute it to a risk factor for seizures. So with the drug abuse, those can be recreational or prescription. A lot of your antipsychotics carry a risk of seizure. And then when you're thinking about recreational drugs, cocaine tends to be one that we see a good bit of seizure activity in with overdose. Other things I could add to this list would be head injuries. And even for children, if their mother used drugs and alcohol while she was pregnant, then there's some link to seizure activity and actually developing epilepsy based on fetal alcohol syndrome and some of those complications from the maternal usage of those things. But for the adults, the most common cause of non-epileptic seizures is alcohol withdrawal, or DTs. So anytime you see NCLEX questions that talk about the patient in DTs, and usually what they want to know is what is your priority of care for that patient, always think safety. I always think seizure precautions. So just put that in your back pocket to remember. But NCLEX loves to ask you about DT precautions and seizure precautions for patients, and that would be your priority of care for them. So what we need to do is have people that are known to have seizures, or maybe even those that are not, but we know they're at risk, to think about how to prevent and manage these general triggers that they might have. There's a list of triggers here. I think it's important to understand that it's different for different people. not everything on the list there would cause a seizure all the time. But when we look at everybody having this predetermined seizure threshold, all of us have it. It's this level of stimulation in the brain that is sort of our max of the amount of stimulation we can tolerate without having something like a seizure happen. So these triggers come along, and these may be these acute insults that kind of push over the level and cause the patient to move past that threshold and have too much abnormal activity, and would cause a seizure. So people with epilepsy, again, need to learn to recognize these things, reduce them, and maybe prevent them if possible, to control their seizure activity and to increase their safety. So our patient education may be around some of these things. Looking at the list there, if I know I have a known epileptic, then I'm going to talk to them about adequate rest. I'm going to talk to them about good maintenance of their blood sugar and eating like they're supposed to, and not drinking, and all these things. So just a couple of triggers listed there, but I'm sure the list is longer for other individuals. Under clinical manifestations here, your book's going to present this in terms of a big tonic-clonic type general seizure. You may have heard them in the community called grand mal seizures. But this is the way the book is going to give you the kind of the classic signs and symptoms, but we'll learn on another couple of slides that there are different types of seizures, and they don't all have this tonic-clonic or grand mal appearance. For sake of discussion, for a general seizure and what would kind of be a textbook generalized seizure, we'll talk about these signs and symptoms and these the way they progress. So it's really an order of things that happens to the patient. So tonic-clonic seizures are also the most common type of seizure in adults. So that's important to note. So whenever the patient sometimes will have a seizure, they may or may not experience an aura ahead of time. So an aura would be something that's a sensory alteration that precedes the seizure. For some people, they see floaters or spots in front of their eyes. Other people may have other visual changes. I had a patient one time tell me that she gets like a metallic taste in her mouth before she would have a seizure. Different things. There's some sort of sensory alteration that kind of precedes and gives a warning that they're going to have a seizure. They train help dogs now to be with children and to recognize and think about the way the seizure presents so that they can help the child get into a safe position when they can recognize that a seizure is going to happen. And I think that's really cool. After the aura, the seizure activity would start and there would be a tonic phase. In the tonic phase, you're looking at all the muscles are sort of holding their tone. Everything is kind of stiff and board-like. And this would go on for several seconds, and the patient would lose consciousness here. Probably are not going to remember that this happened. And then after this short period of this continuous muscular contraction, then we go into the clonic phase, which you probably all have seen at some point, where they alternate between contraction and relaxation, and it's more of a whole body jerking movement. This clonic phase could last several seconds, sometimes several minutes. And then after the seizure activity is finished, they go into this postictal period where they're decreased level of consciousness. They are conscious again, but they're really sleepy acting, very somnolent. Sometimes their respirations will be very deep and almost like Kuzma respirations. And they're arousable, but they just go right back off to sleep, and they just seem like they are so tired. And this whole process could be several minutes long. I've seen patients be postictal, up to an hour. So it just depends on the severity of the seizure and what's going on with the patient. But when you witness this whole process happening, it's very important for a nurse to be able to note the time. what time did this activity start? So if they had an aura and they said to you they had an aura, you would note that time. If not, you just came upon someone having a seizure, you would note that time. Then you would note the time at the completion of the activity. Now, you may not always see the very beginning, but you do your best to kind of gauge the time. The reason this is important is that the longer seizure activity happens, the longer time that you have for airway compromise and hypoxia, and then the longer time that your body is under this increased metabolic demand. And your O2 and your glucose is being used up very quickly because of the muscle contraction and relaxation. That burns up a lot of ATP and a lot of calories, and you become very hypoglycemic very quickly. So it's not uncommon that if someone stayed in a seizure activity state for several minutes, that they could have a risk for death because of the hypoxemia and the hypoglycemia. So you've seen people that, or heard of people that died having a seizure. Lots of times that was probably the reason. So symptoms, again, would depend on the type and the duration, and we're going to talk about some specific types on the next slide. But during that peak of seizure, again, this is a review that the basic metabolic rate does rise, the need for oxygen goes up, the need for sugar and energy goes up, so it's very common that the patient post-ictal will be hypoxic and hypoglycemic. So a couple of your nursing interventions right after a seizure, of course, or during a seizure, would be to try to get their O2 sats, get them on some oxygen, and also check their sugar and give them whatever they need according to that. So here is your list of seizure types. And if you go to your book and look, there is a nice table on page 717, and it gives you all the types of the seizures that we're going to talk about here, what their manifestations are, and how you treat them. So good chart there, 717 and 718. So remember from the beginning of the lecture, I said that partial seizures, and we also called them focal seizures at that time, same difference, focal and partial, that they would affect one part of the brain, one hemisphere, so very localized. So what we're going to see in the patient, again, is going to be very localized. For instance, with simple partial seizures, you're looking at a patient that has really no alteration in level of consciousness at all. This is the only type of seizure that they have no alteration in level of consciousness. This person is completely awake, alert, oriented. But what they might have is one bit of, I'm sorry guys, I was looking at my phone. One bit of motor movement that is confined or abnormal in one area of their body. So does that make sense? Partial seizure or a focal seizure affects one hemisphere, one part of the brain. So then so would what you would see in the patient be similar. So the motor movement, it could be a little twitch of their face. It could be a twitch of their arm or an extremity, but they've got this one piece of abnormal movement. Now, if let's say that seizure kind of started on my left cheek and it moved from my left cheek down to my left arm and then down to my hand, sometimes that'll happen where the nerve impulse kind of carries the message and you'll have this abnormal movement kind of move down the body. And if so, that is called a Jacksonian march or a Jacksonian seizure. And it talks about that in that table for you. Next up is your complex partial seizures. So here we're still dealing with one part of the brain or one hemisphere, but here it's a little different that the patient is not completely conscious. Now when you see that these different seizures have altered level of consciousness, take that with a grain of salt. That doesn't always mean that they are passed out on the floor. It can mean that they are just not as alert as they need to be, or they're not cognizant of their behavior. So, for instance, on this complex partial seizure, they have these repetitive, non-purposeful activities, and it could be aimless walking. It could be walking in a circle, just aimlessly, and they don't even really have an idea that they're doing this. So that when it says decreased level of consciousness, sometimes it can be as simple as that. So these automatisms that they have are these non-purposeful activities. Lip smacking is one, where they would just continuously smack their lips over and over and over during the seizure activity. Or it might be something like picking at their clothes, but it's something that they have no idea that they're doing, and they probably won't even have an idea after it's completed. You'll tell them, look, you were just standing there kind of staring off, picking at your clothes for about 30 seconds, and they won't even have remembered it. So you do have some level of consciousness problems here where you did not have them in the simple partial seizure. Next one there is absent seizures. These are also sometimes called petit mal. So instead of grand mal with a generalized seizure, these are called petit mal. And with this one, it really just looks like someone's daydreaming or kind of staring off into space. With absent seizures, they do have a level of consciousness impairment, of course, and they just all of a sudden they just stop doing all their motor activity, and they appear to be just kind of staring off or daydreaming. Lots of times in children, in classroom settings, the teacher will think that they're daydreaming or just kind of zoned out, but it could be actually seizure activity. So sometimes this goes undiagnosed for years before they realize that the child actually has an issue. So those would be your staring seizures. Then we're looking at tonic-clonic, be the ones that we just talked about, with a big generalized seizure, kind of textbook seizure that has the tonic-clonic phases. And it does a good job in this chart on 717, kind of going through what the patient looks like and how long it lasts and all this good stuff. And then the last piece of that is status epilepticus. This is actually a medical emergency that comes when a seizure is intractable, meaning we can't get it to stop. So we've got a separate slide on that I'm going to come back to in just a second. So with our healthcare team, it's important that we all work together on this, and because we know that this typically affects children, we want to be sure to include their teacher, their school nurse, or maybe it's a daycare worker or whoever is with them all day to know what to do in case of emergency. Thank goodness that many seizures are self-limiting and there's no emergency intervention needed, usually no trip to the hospital. The shorter the better when it comes to a seizure. And we can usually manage this as an outpatient, but if there are a few times where they would have to be admitted. So for diagnostic tests, really look in here at these to try to find the underlying cause of the seizure if we can. So for instance, your CBC, your urine culture, your lumbar puncture would be looking most likely for sources of infection, which might be an insult or a trigger for someone having a seizure. Serum drug levels of like their seizure medications and other drugs to see if they're on therapeutic levels or if they have some toxicity going on. EEG is something you see here in the picture where we measure the electrical brain activity for the patient, and we're going to talk a little more in depth in that in just a second. The reasons I might do CT, MRI, or angiography is to look to see if there's a brain lesion or a brain tumor, or maybe there's just some structural problem in the brain that could be causing the seizure activity. So that's what that would do. And then lead level, that's just one environmental cause, but they list it here to show you that we would also be looking for environmental causes of the seizures. So here's a link, and I'll post this on Moodle as well, but here's a link for a little video that shows electroencephalography, EEG, how about that? They will go through the procedure, and it's important for a nurse to know because we have to do some good patient education for patients getting ready to go undergo testing. So this will be kind of a hot button topic for NCLEX. They want you to know about EEGs and how to educate your patients in regards to seizure care. So I'm also going to put a patient education leaflet up on Moodle that I had a copy of from Southeastern, and that was helpful, I think, to kind of see some of the high points of the patient education. But I'll run down a few of them for you here. The patient has to avoid caffeine before the test because caffeine can affect the brain activity. So they avoid caffeine. They don't want them to sleep much before the procedure. In fact, they would tell them to kind of stay up and not sleep the night before so that when they come in, they can be restful and still, and they might even go to sleep during the procedure. So they like them to sleep less the night before. And there's something about insomnia that helps them see and measure brainwave activity a little better. So I think that's part of the issue too. They do have to wash their hair before, and then they will definitely want to wash their hair after, because when they put these leads in their hair, the little sticky electrodes, that glue just gets everywhere and it's real tough to get out. They can eat. They do not need to be NPO for this. In fact, you want them to have very stable glucose levels because we know we can get some weird activity happening when we're hypoglycemic. So want to be sure that they eat as normal. And then they'll look at their medications, and most medications are fine for them to take that morning, but they'll give them some instructions on what to take and what not to take. Depending on what they're looking at, they may ask them not to take their seizure medications, but it'll really be up to the physician for what they want to see on the brain study. So watch this little video that I put up on Moodle and look at the little handout. I promise you there'll be a test question or so on that patient education, because that is seem to come up frequently on NCLEX. For your drugs, your anti-epileptics or your anticonvulsants, you will hear them call those two things interchangeably. But basically what they're for is not to cure someone of epilepsy. You're not going to cure a seizure disorder, but we might try to reduce or control some of that seizure activity. And it becomes a balancing act. You want to limit the abnormal activity, but preserve the normal activity of the brain. So sometimes we can treat something and we go a little too far. And we want to use the lowest dose possible. So sometimes they'll have to start out really low and titrate them up, or it might take a trial and error approach to get them on the right medication. So it's not a quick fix, but if we can do things to raise that seizure threshold and limit that spread of abnormal activity in the brain, we hopefully can get the patient to a more functional way of life. So here are some education points for your anti-epileptic drugs. This kind of goes across all of them. There are several drugs out there for seizures. Keppra is one we tend to give a lot. Phenobarbital, let's see, Dilantin. There are several, but this would be kind of some generic things that you would give patients that are on these drugs. So it's real important for them to take their seizure medications on time every day at the same time to maintain their therapeutic levels and to help them work the best. They don't need to have this crazy up and down effect of the levels in their blood. So for the same reason, they shouldn't stop their meds abruptly either. They shouldn't be taking medications and then all of a sudden stop, because you're going to have a decrease in that medication in the blood, and it's going to cause a spike in that electrical activity. So you may wind up increasing your risk for seizures at that point. If they're having something like Dilantin, they're going to have blood levels monitored, and so they would need to be educated on that. They need to eat well, they need to rest, reduce their stress level if possible, because these things will decrease the trigger and maybe help reduce the amount of seizure activity they're having. Refraining from strenuous or dangerous physical activity, again, stress on the body may be a trigger. And then it's good for them to wear a medic alert bracelet. So if they did have a seizure out in the community and someone came across them to try to help, they would at least have some indication of what was going on. So if they were a known epileptic, that would need to be on their bracelet. Because as you can imagine, hypoglycemia sometimes will present like a seizure. And so it's nice to be able to see that bracelet and say, okay, they're a seizure risk versus or is it diabetes, is it a sugar problem, or is it both? So that helps first responders help you. So I threw this slide in. Of course, this is not in your book, but I thought it's important if you're going to practice in North Carolina to know what the DMV says about seizure patients. Basically, they say it's the patient's responsibility to report seizure activity or a diagnosis of epilepsy to the state. There is no statutory provision that requires physicians to report. So let's say that I'm hospitalized this week and I'm diagnosed with epilepsy. That physician is not bound by law to notify the DMV or the state of North Carolina. So it's up to the patient to manage that and report that if needed. There is a little bit more stricter guidelines on your commercial driving people or people that have CDLs. If they're known to be epileptic, they have to be seizure-free for 6 to 12 months before they're able to get their CDLs. And it gets kind of bogged down in the rules and regulations at that point. But for just a regular citizen with just regular driver's license, there really is no obligation to report it. So what you would want to teach your patients that have epilepsy is to be safe and protect the safety of others. Not everybody's going to do what they're supposed to do, of course. Some people are going to feel that they have to drive no matter what. But the general recommendation is that you be on medications, be well controlled with therapeutic levels, and be seizure-free for, at least 6 months before you try to drive. It needs to be an individual decision, but as nurses, we always educate about safety. So here's our slide on status epilepticus. Your book's definition of this is a little concerning to me. It says it's a continuous seizure that lasts more than 30 minutes. And I like the second part a little better, that it's a series of seizures. And I think that's what you'll see. If someone had active seizure activity for 30 minutes, this is a sick person and is not conducive to life. Now, I think more commonly what you see with status epilepticus is that you see someone have a 3 or 4 minute seizure. They'll go postictal for a few minutes, and they may, within a few minutes, start seizing again. I think that series of seizures that lasts longer than 30 minutes is more of the definition that you will normally see in practice. And I have seen patients like this that had intractable seizures, and you would give them Valium or Ativan and calm them down, and within a few minutes they were seizing again. So just take that definition with a grain of salt, but it definitely is a problem where you cannot stop or keep the seizure stopped. This is an emergency situation that you do need immediate intervention. What we talked about before, the longer the seizure, the more at risk you are for hypoxia and hypoglycemia, right? So our airway is going to be a priority. And if you give someone enough Valium and enough Ativan, then airway is going to be a problem anyway, right? So this person would probably be intubated at some point once they reached a unsafe level of Valium or Ativan, and then you're thinking about they're definitely hypoxic, so they're going to need to be bagged, or if there's a level of consciousness problem with this as well. They might get D50 through their IV. I would definitely give it IV and not IM, because I know I've got a poor absorption in the muscles because of the tonic-clonic activity that's happening there. The drugs of choice here for seizures in an acute situation would be Valium or Ativan, and I can give that in stacked doses, and so it can be repeated in 10 minutes or every 10 minutes, up to whatever the physician's asking for. And typically we say we do it until the seizure stops. But please be very aware of your respiratory rate and your vital signs while you're doing this. Because if you get into a situation where you're stacking more than 3 or 4 doses, they are going to need to be intubated. For longer term control, we're going to talk about Dilantin. Dilantin would be a medication that we would give probably during this acute situation. You give an IV bolus to kind of get their blood levels up to where you want them, and then we would be doing intermittent pushes or hanging piggybacks of Dilantin periodically. So it might be that they get a bolus dose, and then I'm giving a dose every 8 hours to kind of keep that level where I want it. And it will require labs, and we'll talk about that in a second. But there is a therapeutic level for Dilantin. The last thing on your slide there is phenobarb. We don't use phenobarb very much anymore. It has a high risk for overdose, and when it can be fatal because it causes severe respiratory depression when it happens. So don't give phenobarb a whole lot. I have given phenobarb when nothing else worked, and the patient had to be intubated at that point, and they went to the unit, and I don't know what happened after that, but we had given so much medication on the floor, and we ended with phenobarb. They intubated them and took them straight upstairs. So when all this is going on, your IV fluid of choice is going to be normal saline. So let's think a minute of why that would be. If I'm having to push these medications frequently, and I'm looking at hanging Dilantin, a lot of this stuff does not play pretty together. It does not do well together in the same IV line or the same bag. So your IV fluid of choice will be saline because that's going to be compatible with everything. Alright, so here's a piece that I pulled for you out of the drug book, and it's some information on IV Dilantin. Now, when you're talking about seizure patients, NCLEX loves to ask you about IV Dilantin. So here is some nursing considerations, and I challenge you to look this up on your own. But being the good person that I am, I have pulled you out some pieces on IV Dilantin. And you're not going to find this in your concept book, but certainly if you consult a drug book, you're going to see it. So with IV Dilantin, this is some good stuff, but it's also very caustic to the veins, very unstable solution, and it just does not always do what you need it to do as far as being stable. So we need a large bore IV. A central line is better because the risk of extravasation or infiltration is bad with this drug. We actually have a policy at the hospital where I worked that you could not even put an IV in the patient's hand and give IV Dilantin. It had to be in a larger vein up in the arm or the extremity, and central line was preferred. But IV Dilantin is not compatible with anything at all. It has to be hung and mixed with normal saline. It is not compatible with any of your dextroses or any of your other drugs. So remember that. Whenever you're giving it IV, let's say that I needed to give that first bolus dose, I'm going to administer that direct IV push of no more than 50 milligrams per minute. And that's for an adult. And then if it's an elderly patient, I'm going to cut that in half. And I'm only going to do 25 milligrams per minute. Now the reason we push this so slow is that rapid administration causes really bad cardiovascular problems, hypotension, shocky type situations, CNS depression, bradycardia. It's just not good when you push it too fast. So you have to be very careful about your rate of 50 milligrams per minute. Now, when I'm drawing this up to give it IV push, I have to use a filter needle when I draw it up. Because remember, I said that if you drew it up without that filter needle, you've got the risk of it being unstable, and it will actually precipitate out little particles if it's left standing too long. So when I draw it up, I use that filter needle to make sure I don't have any of those particles precipitating out and push that into my patient. After you give a bolus dose, and you're usually going to do that IV, direct IV, Then periodically you're going to give intermittent dosing to kind of keep that level up where you want it. So with intermittent infusions, we can look at diluting the dilantin in no more than 50 milliliters. The reason I wouldn't want to dilute it in 100 or 250 milliliters is because it needs to run in fairly quickly. Infusions should be in within an hour because, again, it does not like to be stable very long, and it will actually precipitate out in that bag. So you can't leave it hanging for long periods of time. So immediately after mixing it, I'd hang it. I'd complete my infusion within the hour, and I cannot exceed 50 milligrams per minute. So that's that same kind of idea with the IV push or the intermittent infusion. You do not exceed 50 milligrams per minute. And if it's an elderly person, then consider 25 milligrams per minute. Here we're using an inline filter on the IV tubing, again because it's not stable. And then you're only mixing it in normal saline because that's the only thing it's compatible with. Here's your dilantin level. We're looking for therapeutic from 10 to 20 mics per milliliter. All right, so we say all that to prevent this. This is purple glove syndrome. This is specifically a complication that we see with extravasation or infiltration of an IV with dilantin. So this is why my hospital has a policy that you do not use hands or small veins for the IV dilantin. Central line is preferred. So I've seen this one time in practice in 22 years, just one time, thank heavens, and it was a patient's pinky. And they had come up from the ED, and they had been in status epilepticus, and they had given them dilantin in the ED, and they couldn't get a line on them. And why they didn't put a central line in, I'm not sure. But you've got a little vein that runs right to your last knuckle, kind of down your pinky, and they had used that little vein, and they had, I can't remember if it was a 22 or a 24 in that little hand. And when they gave the dilantin, it blew, and so they had this extravasation of dilantin. And that patient was in the ED for a couple hours, came up to the floor. I took care of them on the floor. And when they came up to the floor, they already had this purple discoloration, swelling, heat. It was a hot mess. So they did several things related to steroids and things to try to reverse, and I think they put them on antibiotics. They did all kinds of things and had surgeon look at it. And they messed with it for about a week, but that patient wound up losing that pinky finger. And it was a whole big thing. So remember when you give dilantin that this is a risk, and please always push it slow, always dilute it if possible, and just be real careful that you've got a good IV before you start. Phenergan is another one of these drugs. Probably won't do this level of damage, but Phenergan is rough on veins. So please be sure that you're diluting Phenergan when you give it, and you're using the same kind of precautions. Okay, for children, typically we don't treat seizures in children, particularly if they're febrile seizures, because the best thing to do for that is to treat the cause. So if they have an infection or something going on that spiked a fever, then that's what we're going to treat. We're not necessarily going to give them seizure medications. Of course, we'd want to protect them from injury. If they have one febrile seizure that we know that they're likely to have another, maybe not with this illness, but it could be even 6 months later, that they tend to, once you kind of reach that threshold, it's a little easier for you to reach it the next time. So for that reason, if a child is going home and they still got an active infection and you think their risk is high, then they may give the parents rectal Valium. It comes in a gel for them to be able to administer at home. So we need to teach our parents about that. We may hospitalize children that have a big generalized seizure that lasts more than 10 minutes. And that would be, of course, to monitor their electrolytes and their ABGs, get whatever problem they have that caused the seizure under control. They may put them on anticonvulsives if this is an unprovoked seizure that's not caused by something as simple as a fever. And then when they go home, they're going to need a seizure action plan for school and daycare or wherever they might be during the day. Whoever's taking care of them needs to know what to do, who to call, what kinds of things to do to activate the emergency system, whatever is needed. And for kids, they really like them to be on one drug at a time. One drug will reduce the likelihood of side effects, and sometimes whenever you look at multiple drugs, it becomes difficult to dose them by weight. So they'd like one drug to be used and, of course, dosed by weight. And then as that child grows, all they need to do is adjust the level for their symptoms and their drug levels. But we do a lot to try to limit them to one drug. But with kids that have intractable seizures and we can't get them under control, then they may be on multiple medications. There's also a diet that children can do for new epileptics. It's called ketogenic therapy. And basically it's high fat, low carb, with normal protein levels. And what they do is put the child on a 24-hour fast to start with, and that puts the body in a state of ketosis because the body starts to break down fats and it gives off ketones when it does that. So as it continues to increase the fat usage, and then they have low carbs so that they really don't have the carbs to burn, it evokes this kind of ketosis. And there's something about the ketones in the blood and the system that has an anticonvulsant effect. As you can imagine, the success would improve with compliance. Can we get children to do this? Can we get parents to do this for their children? And it'd be hard for kids, right? Because if they're not having a lot of carbs, they're not having a lot of the sweet treats that kids usually enjoy. Complications of this diet are important to note as well. With this very high fat content in their diet, they're going to be at risk for constipation. They're going to be at risk for kidney stones that are made up of that fat content, and high cholesterol levels even. This reminds me a lot of the Atkins diet that some people do. So getting into that ketosis state is what seems to be helpful for the seizure activity. If a child becomes seizure-free or stays seizure-free for 2 years or more, they would try to withdraw and taper off the seizure medications and just watch them for symptoms. It seems that if they can withdraw these medications in children, they have a lot better success rate of getting them off medications. It seems that the older you are when you're diagnosed and put on anti-epileptics, the harder it is to come off. So for an adult that's diagnosed, they typically are looking at lifelong therapy versus a child who could be tapered off while they're still young. So under assessment here, we're looking at the history. Whether it was you or someone that was with the patient, someone needs to describe the seizure. And physicians will ask you this, how long did it last? What did it look like? What did the patient do? What did they say beforehand? Did they lose level of consciousness? How long did it last? And all these things will tell us or give us some insight into what type of seizure it was and how severe it was, because we know that the longer the seizure, the more at risk I am for some of those complications. So on my examination, I'm going to be looking at a good neuro exam. So if you need to go back and review that, please do so. And again, that's in the front part of that chapter. Looking at their level of consciousness, their physiological state, their vital signs, of course, hypoxia, blood sugar, and it may be very different just depending on the type of seizure and the individual patient. Here are our diagnoses. Looking at ineffective breathing pattern. During a big generalized tonic-clonic seizure, we can have apnea when they're in that tonic phase. So as everything is kind of clamped down and toned up, and we're just kind of holding stiff, sometimes even your respiratory muscles are also at tone. So you might have an ineffective breathing pattern related to apnea. And this may be a huge cause of our hypoxia as we continue on through the seizure. Ineffective airway clearance can come from loss of control of their secretions. Patient may even be at risk for aspiration because they can't control their secretions. So one of the things that we do for someone actively having a seizure is get them on their left side whenever we can or when it's safe to do so. Risk for trauma there, injury. One of the best things you can do for someone who's having a seizure is just try to move things away from them. In years past, we looked at could we, you'd have people trying to restrain their movements, and we found that that causes more injury than not. So the best thing to do is just move things away from them. So if they're banging their arm on the side of the desk or the chair, then you move that object away from them to give them room. Chronic low self-esteem would go with the kind of the social stigma and the embarrassment and the uncertainty that comes along with a seizure disorder. We know that whenever you have a seizure, you not only lose loss of control of your secretions, but may also bladder and bowel control as well. So having to have patients understand this and what the ramifications of that are, and having to listen to their concerns about that is important. Anxiety is there. Ineffective therapeutic regimen management would deal with if they were non-compliant with their medications or their lab follow-ups or what have you. And then the last thing there is readiness for enhanced family processes. This is a positive diagnosis. Lots of times we tend to always talk about the negative things, but when you see the word readiness in front of a diagnosis, I know that that is a positive mindset. This is something that the patient has demonstrated some readiness usually to learn about something. So this may be a family that is asking how can they help and how can they better support their family member. So that would be a good thing, and your interventions would normally center around teaching. So that's good. Planning here, we're going to focus on safety. That would be number one. Airway is right up there as well. Administering their medications, and I need to have some good understanding of what medications they give and when and why. And then providing an emotional support system for them. So here's some implementation things. Do not place anything in their mouth. Years ago, we used to always tape bite blocks to the head of the bed for people that were on seizure precautions, but no more. We found that that really causes more energy, not energy, but injury, and it just really doesn't do anything for them. Position them on their side so that secretions can drain as soon as it's safe to do so. Monitor to ensure their adequate oxygenation, put them on O2, protect them from harm. So whenever in the hospital we have seizure precautions, you'll see padded bed rails, and then things like bed alarms, things of that nature. Frequent seizures, particularly in children, you may see them even use helmets because you might think of them having falls or becoming unconscious quickly where they would sustain a fall. Medic alert bracelets are good. And then we're going to be really careful when we administer those IV meds to make sure that we are not causing further problems with tissue damage. We're going to help them with their medications. And it's important for children, for parents to understand that they need to treat the child as normally as possible. Now that's hard. When you've got a sick child, you've got something chronic going on with the child, you tend to want to overshadow or overprotect them. But they need to be allowed to socialize and to play sports and do whatever is within reason. And of course, your doctor would be consulted on those decisions, but as normal as possible. And the activity needs to be as normal as possible. There are support groups that we can put them in touch with. The Epilepsy Foundation is awesome, and they have online resources and things for patients and families as far as education and ongoing support. And then just being therapeutic, encouraging them to talk about their fears, their anxieties, their self-esteem, and just remembering your good therapeutic responses to those things. So here's our evaluation. We want our patient to have good seizure control, and whatever method or treatment that might be, help them along with that, help them to understand it and to comply with it, help them to have a good self-esteem and be as normal as possible as far as their activities. Patent airway, good oxygenation, medication administration, making sure they know how to take their meds and how to monitor their blood levels, and then a good seizure management plan for everybody involved with this client, from the healthcare team to the school nurse to the babysitter to whoever it might be that's going to be in contact with this patient. So that's pretty much it for the seizure piece. So on Moodle, I will put up a link to the EEG video, a link to the EEG little handout, patient leaflet thing. And also I've got some practice math quiz questions that I'm going to put up because we do need to know how to figure our Dilantin. And if I'm going to look at a Dilantin dose and I know I can only run it 50 milligrams a minute or push it 50 milligrams a minute, I need to be able to figure that out. So I'm going to give you some weight-based Dilantin practice problems for you to work through. And then when I get back on Monday, after next week, I will go over those with you and make sure you're good on it, because you will have a question or two about that. Okay, thanks for listening.